Thank you for the invitation to talk today on new ways that we are treating melanoma. It's a very exciting field to be in. My name's Dr Georgina Long. I'm a medical oncologist and clinician researcher here at Westmead Hospital and Melanoma Institute Australia. So what I wanted to do first is put melanoma in the context of cancer in Australia and give you an idea of the scale of the problem. So 1 in 3 Australians will get cancer. 100,000 cases of cancer occur per year in Australia, and there are 40,000 deaths due to cancer per annum. It is the largest contributor of disease burden in Australia. So I have a slide here showing cancer risk by age of males first. So these are the 4 major cancers that affect males. Firstly, melanoma in red, prostate cancer in blue, lung in yellow, and colorectal in green. And you can see on the x-axis that we have age time points. So from age about 15 to 50, you can see that the red curve dominates. So from 15 to 50, melanoma is the highest incidence cancer in males. After 50, as the population ages, other cancers take over, particularly prostate cancer. If you look at females and look at cancer risk by age, and the same thing with the x-axis, you can see the age period from about 15 to 30 is dominated by the red curve, which is melanoma. After about the age of 30, breast cancer takes over. It's also important to note that people less than 40 tend not to get cancer, or so we think, but melanoma is the highest incidence cancer in that age group. Melanoma then continues to increase and in fact is much more common in the elderly than young people. So if you look at this table and look at melanoma incidence in New South Wales, you can see that from 15 to 30, melanoma is the most common cancer. From 30 to 50, it's the second most common, and then from 50 on, it sits at the 4th most common, right up for all ages and above 80. In this diagram, you can see that the changes in cancer incidence in the last decade show that things like lung, bowel, prostate have all decreased in incidence. But you can see that melanoma has actually increased in incidence with a 32% increase from 1995 to 2000. Again, for women, the same pattern. Although lung has not decreased as much as it has in men, melanoma has increased by 20% in the last decade. This slide hasn't come through very well on this projection, but what it did show is the different rates of melanoma amongst different ethnicities in the US. So they have a white, Hispanic, black and Asian mixed population. And you can see that melanoma is much more common in the white population. It's really a disease of Caucasians. So at the bottom there I have a picture of what we call the Fitzpatrick skin type. And that is a medical classification of how much pigment you have in the skin. So Fitzpatrick 1 and 2 skin is very fair, 1 being very fair with very light hair, light eyes, 2 being only slightly darker, and that is where melanoma usually occurs, although it can occur in people of Asian and black descent. It's very rare. What are some of the other risk factors for melanoma? There's a syndrome called dysplastic nevi syndrome where people have quite a few moles. We have to remember that not all melanoma arises from a mole. It can just arise on its own. But people who have a lot of moles, a heavy burden of moles, are at increased risk of melanoma. You can see the picture on the right of young children in the sun. Sunburn, especially in childhood, is also associated with an increased risk of melanoma. If we look at this slide of melanoma around the world, you'll see that Australia has the highest incidence of melanoma than any other country in the world. So it's a real problem for us. It is Australia's cancer. In this picture, I have the solar UV pattern from the northern hemisphere in their summer versus the southern hemisphere in our summer in January. And you can see by the heat pattern that the summers in the southern hemisphere are much stronger. We think that's an effect of aerosols and pollution rather than loss of ozone layer, but it means that melanoma is more of a problem for us down in the southern hemisphere. And another risk factor that's very important, and it's gaining media attention as it should, and hopefully some more political attention, is use of sunbeds. We know this is a particular problem for those who are young. Sunbed use causes 16% of melanomas in those less than 30. And in fact, of all people less than 30 who suffer from a melanoma and have used a sunbed, 76% of those melanomas are directly attributable to a sunbed. In fact, just one use of a sunbed can increase your risk, but overall, any use of a sunbed increases your risk of melanoma by 1.41 times compared to those who don't use a sunbed. So I'm now going to talk about the structure of the skin and explain a little bit about what is melanoma. So in this diagram here, you can see a cartoon of the layers of skin. There's the epidermis at the top, shown in purple. Within the epidermis at the top, you can see the hair coming out and the follicles, but you see these little dark black dots. They're melanocytes. They are the pigment-carrying cells of your skin. They make the skin the colour you have. At the very top are keratinocytes, which are the protective layer of the skin. It's a barrier. Below the epidermis sits the dermis, which includes the hair follicles, sweat glands, blood vessels, nerves, and under that, the subcutaneous fatty layer. So here's a diagram now of a large melanocyte, the pigment-containing cell I explained that sat in the epidermis, the bottom of the epidermis. And I've got a picture of the nucleus in purple here. So the nucleus contains the genetic material of the cell, tells what the cell to normally do. Inside the nucleus we have DNA, and we know that if you have high exposure to UV light from sun, that can damage the DNA. And what that results in is an abnormal cell. So the melanocyte, which is normal and normally sits in the skin, can become a melanoma cell. A melanoma cell is a cancer cell. So here, back to the cartoon with the layers of skin, you can see that if a melanocyte, which is normal, becomes damaged and becomes a melanoma cell, it reproduces very quickly, it's uncontrolled in its division, and it becomes a lump or a melanoma, which is shown here on the surface of your skin. Now the good news is that early detection of melanoma can cure it. In fact, 85% of melanomas are cured if detected early and can be resected. This is a picture of Arnold Schwarzenegger, and back in 1985 he was diagnosed with a melanoma, which you can see here on his cheek. He's had no problems as far as I'm aware since. He's alive and well in his 60s. However, there are a proportion of patients who unfortunately are not cured just by surgery, and they develop what we call metastatic melanoma. What is metastatic melanoma? That is where the melanoma cell, the cancer cell, has escaped from its original primary location on the surface of the skin and disseminated in various places in the body. It can plant its home in the lung, in the brain, in the liver. It can even plant a home in big lumps under the skin, in your bowel, in your lymph nodes. It's generally rapidly progressive. Only 50% of people would survive beyond 10 months, and only 5% of people with disseminated or metastatic melanoma would survive to 2 years. Those with brain metastases, where the melanoma has gone to the brain, survive 4 months on average. Chemotherapy is more or less ineffective. Surgery is more or less not a cure for this sort of disease. 90% of patients do not respond to chemotherapy with disseminated metastatic melanoma. 8,000 to 10,000 Australians per year suffer from metastatic melanoma. So it is a big problem for us in Australia. Well, what are we doing about it? So we need some new treatments because the chemotherapy clearly is not working. The other point to make is that melanoma takes a disproportionate toll on young people. For every melanoma death, we lose 18.6 years of productive life. So it's an effect that affects all of us, not in a personal way in terms of family, but the community. So now I'd like to turn to the BRAF story. And this is the good news story of some of the work we're doing to try and improve the outcome of patients who have disseminated metastatic melanoma. Remembering that the majority of melanoma is curable, this is just a small proportion of people. So what is BRAF? BRAF is a normal protein found within normal cells. We all have BRAF within our normal cells. It is important for the normal cellular function of our cells. So here I have a diagram showing a big green normal cell. Within it, in red, is the normal BRAF. We call normal BRAF protein wild-type BRAF. I have a star on the outside, which is a signal from the outside world to tell the cell to do what it should do. It's a control point. The cell needs to be told time to divide. So when the cell is normally activated, BRAF then becomes activated, and then the cell will divide and you'll have two normal daughter cells, and that's a normal process. So what happens when you have mutant BRAF? So the BRAF protein is mutated and abnormally signals to the cell to divide, to migrate, to survive much more than it should. And this is common in melanoma, in about 50% of melanoma that's disseminated. So here's a diagram showing what happens. You no longer need that signal from the outside world. There's no control over the cell from the outside world. BRAF is just activated and continually stimulates to the nucleus to divide, and the cells divide and divide and divide. So BRAF mutations in melanoma, as I mentioned before, are quite common. So we've done studies looking at the rate. It's 50% in the Australian population. The most common type of mutation or name for the mutation is called V600E. But we've discovered that a high proportion of patients also have another type of BRAF mutation called V600K. And this is important because of the drugs we're trying to target this BRAF mutation and kill the melanoma cells. There's no specific phenotype for BRAF. What I mean by that is, as a doctor, if a patient walks in the door with disseminated melanoma, is there anything about the behaviour of their melanoma that tells me it's going to be BRAF mutant? No, there's not, except youth. People with the BRAF mutation tend to be young. So we looked at a large number of patients here at Westmead and Millennium Institute Australia, and in this diagram you can see that we tried to pinpoint what the proportion of patients in each age decade, what the proportion of BRAF mutant was. If you're aged between 20 and 30, there is an 86% rate of BRAF mutation, so it's much higher in the young. If you're aged over 70, the BRAF mutation rate is only 22%, so it's much lower in the older population. Looking at it another way, if you divide it into sort of three broad groups, those less than 40 have a mutation rate of 80%. Those aged between 40 and 70 have a mutation rate of 50%, and those aged over 70 have a mutation rate of around 20 to 25%. So what are BRAF inhibitors? These are drugs that block that abnormal mutant BRAF action. So this is another cartoon diagram showing you how these BRAF inhibitors work. So this is a cell, a melanoma cell with mutant BRAF. It does not attack your normal BRAF cells. And the BRAF inhibitor blocks the action of that mutant BRAF. This is one of our patients who has multiple subcutaneous disseminated melanoma. You can see the areas of melanoma under his neck, on his shoulder, and then there are 5 areas at his lower back of melanoma. He's very unwell, he's lost a lot of weight, his appetite's disappeared. The tumour releases chemicals that switch the body's desire to do things off. They're very tired. The amazing thing is when we started one of the BRAF inhibitors, vemurafenib, there were actually 2. Within 24 hours his appetite had improved. Within 6 days, as you can see on this photo, the lumps, particularly around the lower back, have almost disappeared. So by day 42, you can see he's gained weight, he's back doing things he'd like to do, preparing a photo album, writing a book, running marathons, and you can see that the lumps on his back have almost all completely disappeared, particularly the one up at his neck and the 5 down at his lower back. The one on the shoulder has shrunk considerably, but there's still a little bit of residual melanoma there. So that is one of the problems with the drug, is that it does switch everything off and the cells die and shrink away, but sometimes not all the lumps completely disappear, and eventually they do start to grow after a number of months. That's called resistance. Here is a PET scan. A PET scan measures the metabolic activity of a tumour. You can see on the left the black areas, particularly the shoulder and in the middle of the torso, are all areas of melanoma. By day 15, the black areas have switched off. That area in the middle is the heart, which is normal. That usually lights up on a PET scan. So you can see that the metabolic activity of the melanoma cells, the cancer cells, is switched off within 15 days of starting a BRAF inhibitor. And then the cells begin to die. If you look at a CAT scan or a CT scan, the top row shows the day 0 scan with the lumps of melanoma. The first one shows areas in the lung with arrows pointing to them. The middle one shows very large liver metastases of melanoma. And the third one shows a bone metastasis, you can see with the arrow in the corner. By week 8, you can see that almost all the lung metastases have completely disappeared. Those small little white dots are normal vessels in the lungs. The liver lesions have shrunk considerably, and you can see the bone lesion. There's now normal white bone, and you can't see the melanoma lesion anymore. So this is one of the trials that we have been participating in at Westmead Hospital of one of the BRAF inhibitors, vemurafenib. These are the results that were just recently presented at one of our large conferences. You need to remember that when we're developing drugs, there are 3 phases we need to do with a drug. The first thing is to first test it in humans and check how toxic it is. That's called a phase 1 trial. The next is then to check whether the drug is active in the cancer. That's called a phase 2 trial. Then a phase 3 is the final trial we need to do, where we check it against our current gold standard of care. So what I'm showing here is results from the phase 3 trial with this compound. It's incredibly quick development of this drug, and in the period of 2 years we got to a phase 3 trial, which is from phase 1 to phase 3, which is absolutely phenomenal. The reason being is that there was just really nothing in melanoma, and we just had such a demand for these drugs. So the top curve shows the BRAF inhibitor, vemurafenib. Each individual yellow line is an individual patient. There are over 300 patients on the vemurafenib arm. Patients were randomised to either receive the BRAF inhibitor or just the standard chemotherapy. So the top curve are those who got vemurafenib, and you can see on the y-axis, if it's less than 0, if the bar is less than 0, there have been shrinkage in the tumour. If the bar is above 0, there's been growth in the tumour. And you can see that the majority of patients, over 90% of the patients, have had shrinkage. But we only call a response if we've had shrinkage of 30% or more. So the formal response rate, we quote, is 48%, although we know from this curve that 90% of patients actually benefit with some degree of shrinkage. Now looking at the bottom curve, it's completely opposite. This is our old standard of care, dacarbazine chemotherapy. The response rate is 5%. And you can see that the majority of patients have growth in the tumour and never actually have any positive response with the chemotherapy. This is the other BRAF inhibitor currently called GSK 2118436. We've been very active in the research of this compound as well at Westmead Hospital. This was the results of the phase 1 trial in melanoma patients, so just checking for toxicity. You wouldn't normally expect to see fantastic results in a phase 1 trial, but again you can see from this waterfall plot, each bar is an individual patient, that the majority of patients, in fact all of them, have had shrinkage in their disease except one patient of the 26. This is a response rate of 77%. Here is a picture of the liver CT scan, CAT scan, in an 82-year-old patient who had the V600K mutation. Remember I mentioned V600E is very common, K is very common in the Australian population as well. And even that group responded to the GSK compound. You can see these dark spots in the liver there on the left, and by week 6 they've almost completely disappeared. The additional thing that we've been very active in at Westmead is brain metastases, because melanoma goes to the brain often. So this is one of our patients, and you can see there's a yellow arrow pointing out a small brain metastasis. She had 4 of those lesions, but only 1 is shown on this picture of the MRI of the brain. By the time we got to week 7, it had completely disappeared, and in fact all of the 4 brain lesions had completely disappeared. She had a continued response beyond week 18, which is absolutely phenomenal when you think that most patients with brain metastases only survive 4 months, and we managed to completely eradicate her brain disease for at least 18 weeks. This is another patient who had very heavy burden of brain metastases. He had 20 brain metastases. On this single slice of the MRI, you can see 8 brain metastases in white. By week 4, they've shrunk. By week 10, almost completely disappeared. And he got a great benefit in terms of quality of life with that period of shrinkage. This is a picture of one of our young patients, just to show you the benefit we see with this drug. Although the drug does not work, it's not a cure, it doesn't take it away forever, it gives people wonderful quality of life for a period of time. She was very unwell, requiring blood transfusions. She had a lot of fluid in her abdomen. She was bedridden. When we started the drug, within 2 months, you can see she's packed up her bags. In fact, within 2 days, she left hospital. She went back to doing her PhD studies in history. She published 2 papers. She went overseas. She had a wonderful quality of life. Unfortunately, the disease did come back after about a year. But she had a great quality of life with her family, achieving goals she'd like to achieve. So I just wanted to highlight what happens is, first of all, symptoms disappear within the first few days. People's performance status picks up. They start gaining weight, they go back to work full time. They go back to studies, they do things that they were looking forward to doing, run marathons. You can see that the metabolic rate of the tumour switches off within the first 2 weeks, and by 6 to 8 weeks we see a shrinkage in the CAT scan of the tumours. This is data from our group as well, looking, well, what is the median overall survival of patients who get an inhibitor versus those who don't, so we can get an idea of the actual benefit. So in our 311 patients, this is called a survival curve. At the top on the left, you start with 100% of patients. And unfortunately, with time, people succumb to metastatic melanoma. But you can see that the top yellow curve slowly decreases, and that's the patients who've had an inhibitor. Whereas the other 2 curves are either patients without a mutation who don't get an inhibitor, or have the mutation and were not able to access an inhibitor. And you can see that their curves decrease very quickly, so people die very quickly. The 50% of patients who have the mutation and get an inhibitor survive more than 1.8 years. So it's a great effect, although we have to remember it is only the beginning, and unfortunately patients do develop resistance, and this is not a cure. So how can we move forward? How can we move from making disseminated metastatic melanoma a chronic illness rather than a terminal illness, because it still is a terminal illness? Here at Westmead we have a trial called the TEAM trial, where we collect tissue from patients with metastatic melanoma who are very brave, who we collect a piece of tissue before they start a BRAF inhibitor or any new drug. We collect a piece of tissue 7 days after, and then we try to collect a piece of tissue on progression. And what we're trying to understand is how the drug acts and how the drug becomes resistant, or how the melanoma becomes resistant to the drug, so that we can come with new drug therapies and new combinations of drugs to try and improve patient survival and quality of life. And so this is my last slide to end on another hopeful event, and that is we've already finished the first in humans phase 1 study of such a combination of drugs, of a BRAF inhibitor with a MEK inhibitor. We haven't got the results of that study yet, but it looks promising, and we're hoping that we can extend the survival even further. We do this work in collaboration with scientists from the Westmead Institute of Cancer Research and Westmead Millennium Institute, along with people from Melanoma Institute Australia. And we've really made amazing gains together internationally and nationally in the last 2 years. I'd like to acknowledge the patients and their families. I'd like to acknowledge my national and international colleagues and scientists. Professor Rick Kefford here at Westmead Hospital, the Westmead Hospital staff, Trials Unit and at Melanoma Institute Australia, and the Westmead Millennium Institute scientists and the research support. Thank you.